will put my chats in the box.
Problem. No problem.
Good morning, everyone.
Keep an eye out.
Good morning.
Hello.
Wow. Well, I'm going to welcome everybody in, although I'm keeping an eye out for more participants. So I'm Dr. Sachs, and I am faculty at Chestnut Hill College, and I'm also have the blessing to be Hannah's dissertation chair. I've really enjoyed working with her on this project for several years, and during that time, she has accomplished so much, including finishing all of her academic requirements, just completing her internship, and having a baby. So it's really a lot to behold. And Hannah, we're really looking forward to hearing your discussion today.
Thank you. Thank you so much, Dr. Sachs. Should I pull up the PowerPoint now, or should I wait?
Absolutely. I will go ahead and enable your sharing.
Okay, great.
Okay, there we go. Let me know if it doesn't work.
Okay. Okay. Can everyone see this?
Mm-hmm.
Okay, there we go. Can everyone see that? Okay, great. Should I wait a couple minutes?
I think you could go ahead and get started, and if
Okay.
anybody else arrives, I'll be sure to let them in.
Perfect. Okay. Good morning, everyone. Thank you so much for attending my defense. Everyone knows who I am. Dr. Sachs is my chair, and my two committee members are Dr. Rothery and Dr. Methacolum. And I will thank them a bunch at the end for all the support and the feedback they've given me over the last several years. So my study is on how does working in long-term care settings with older adults impact psychologists' attitudes toward aging. So a trained psychoanalyst once said, her name is Karen Horney, man can change and go on changing as long as he lives. And I thought that was a quote that is pretty relevant to this study. So the rationale for my study is that I implemented this with the hopes of uncovering a variety of experiences with a potential pattern for further research on the impact of ageism and geropsychology training through the eyes of the geropsychologists themselves. In 2020, a poll was conducted, and it was taken on, sorry, is that me? Is that me?
No, but if people can mute when they come in, that would be great.
Okay, I wasn't sure if that was my headphones. So in 2020, a poll was conducted on older folks' experiences on everyday ageism and the associated impact this can have on health and well-being. So the participants were more than 20,000 adults in the US, and they were from 50 to 80 years old. The results of this study are that more than 8 out of 10 said they experienced one or more forms of everyday ageism. 65% of respondents reported exposure to ageist messages in the media that portray aging as unattractive, undesirable, or worthy of ridicule. Almost half of the participants said they've encountered ageism in everyday interactions, and a third of participants responded to the questions in ways that suggested they personally have negative beliefs about aging. So this was very telling and is telling about the current status of misperceptions of aging or ageist attitudes. So many people think depression and loneliness is an inherent part of aging, but research shows they are not. So part of my literature review, the introduction for my study, as life expectancy has increased and a generation of baby boomers approaches 65, the population of older adults is rapidly increasing. So skilled nursing homes, otherwise known as SNFs, also known as nursing homes themselves, are institutional facilities licensed by the state that offer 24-hour room and board, supervision, nursing care, and the experience of living in long-term care facilities varies based on environmental factors, systemic and individual factors, rates of mental disorders can all vary by setting. So some examples of environmental factors could be the location of the facility, the specific older adult population that it serves, resources, things like that. So resident gender, socioeconomic status, education, and cultural factors all play a role in the mental health outcomes of nursing home residents. So the culture of skilled nursing facilities, it can influence the behaviors and attitudes of employees interacting with their residents. So factors such as the employee's perceived impact on their environment, their values, their own beliefs, all have a significant impact on resident mental health and well-being. For example, if employees are empowered by education, resources, autonomy, decision-making, and responsibilities, they appear to value and concentrate more on resident needs rather than their own. And that certainly will increase quality of care. So clinical concerns among older adults. The most common mental health concern in older adulthood is anxiety, severe cognitive impairment, and mood disorders such as depression and bipolar disorder. However, researchers and doctors believe that overall, anxiety and other psychiatric disorders decrease with age until they reach the oldest old group, 85 plus. So the older adult bracket is distinguished with subcategories. So the youngest old is 65 to 74, the middle old is 75 to 84 years, and like I said, the oldest old is 85 plus. Although depression may increase with age, it's not a normal part of aging, and therefore it can be left untreated or sometimes misdiagnosed. Diagnosing mental health in the elderly can be difficult because changes in physical and psychological functioning may mimic psychiatric disorders. So the impact is that this could leave older adults undiagnosed with mental health conditions and other age-related circumstances. Older adults experience more drug interactions and drug side effects due to taking several medications at a time. So that way, the reason that it is important to have wholesome treatment and coordinated management of care is so these issues and concerns and symptoms can all be teased out. There's every part of the team, so the doctors or the therapists, all know what is going on with the individual, and therefore they're getting the best treatment possible. Drug interaction and age can change the absorption, metabolism, and even the efficacy. So that's why it's another reason it's really important to have coordinated management of care, because there are comorbid conditions, and that's more likely in older adulthood. Also, differentiating between normative grief and depression after losing a loved one, that can be very common in older adulthood, and that's why it's important to tease these things out. Memory problems, isolation, and withdrawal can all be due to depression or early signs of dementia, medication side effects, or even medical conditions. So again, that's why it's extremely important to have coordinated management. Perceptions of aging. Ageism is a term coined by Robert N. Butler in 1969, and it is defined as a deep, profound prejudice against the elderly. Examples of culturally influenced ageism are reflected in statements such as, "You can't teach an old dog new tricks," or "Therapy change is pointless because there's little time to benefit." Ultimately, they, older adults, are going to die. So today, many older adults in the United States are marginalized, institutionalized, and stripped of responsibility, power, and even their dignity. Several generations ago, older adults were viewed as teachers and in high regard. Older adults were thought of as wise due to their greater experience. However, views began to shift with the onset of the Industrial Revolution, because there was a demand for mobility in families. So older people were not as mobile, and jobs were oriented toward long, difficult, and manual labor. So as a result, American culture, the attitudes toward aging have changed over time, and due to advances in medicine, life expectancy increased, but old age was negatively perceived because our society is not necessarily equipped to handle our aging population. So another part of ageism is the patronizing language, such as overaccommodation and baby talk. So overaccommodation is defined as being overly polite, speaking louder, speaking slower, exaggerating intonation, using a higher pitch, and using simple sentences. So when people overaccommodate with their language, it's usually due to their assumption that the older adult has hearing problems, decreasing intellect, and slower cognitive functioning. Infantilization, or elder speak, is another form of patronizing language, and this creates a self-fulfilling prophecy where older adults accept and believe that they are no longer independent and contributing adults to society. Instead, they believe themselves to be passive and dependent. Ageism, unfortunately, is often observed among helping professions in American culture. So the impact of this research shows, as you can imagine, the views about aging are becoming more and more negative, and many misconceptions remain about the aging process. Healthcare professionals sometimes see illness as a natural part of the aging process, and therefore they place less emphasis on it as a topic of research to help older adults cope and manage. It's important to explore how biases may influence the work of geropsychologists and how we take care of this population. Internalized ageist stereotypes and fears about aging on the part of the therapist may negatively impact both members of this dyad. So this can also result in less effective care. These negative attitudes may also prevent psychologists from specializing in geriatrics, resulting in a continued lack of qualified providers. So the role of a geropsychologist. A geropsychologist provides services to older adults and sometimes their families. Services delivered in a variety of are delivered in a variety of settings, which include outpatient, inpatient medical centers, mental health, and long-term care settings. Geropsychologists can provide psychotherapy, assessments, and consultation, and they use a variety of individual, group, and therapy models, including behavioral, cognitive, interpersonal, problem solving, and systemic approaches. So the geropsychologist's attitudes and experiences. Countertransference is defined as the clinician's feelings being transferred onto the client, or a therapist's a therapist's emotional entanglement with a client. So if we go back many years, Freud viewed countertransference as problematic, something to be managed and done away with. Later theorists viewed countertransference as a therapist's inevitable reactions to his or her client. So what does this mean? Countertransference can be beneficial if the therapist explores and examines these reactions and uses this understanding to better understand their client. Contemporary psychology distinguishes between helpful and unhelpful countertransference. So helpful countertransference is accomplished when a clinician uses this to understand differences between their own experiences and the experiences of the person in therapy. On the other side of this, unhelpful countertransference can occur when the clinician transfers misplaced feelings onto a client, so emotional entanglement, or uses a client to meet personal psychological needs. So the Pikes Peak model for training in professional geropsychology, this was a pretty important part of my literature review. It's a competencies-based approach, which was developed to address the skills, knowledge, and attitudes necessary for competent work with older adults. So these competencies are applicable across varied geriatric care settings and population, like I discussed earlier. Competent geropsychology practice involves attitudes, knowledge, and skills regarding assessment, intervention, and consultation for older populations who may present with age or cohort-specific needs. An important aspect of this model is that these suggested competencies are aspirational rather than required. This means that the best geropsychologists out there will have relative strengths and weaknesses among these core competencies. So it's important to recognize the scope of competence, the self-awareness that the geropsychologist has, their own attitudes and beliefs about aging and older adults, appreciation of diversity among older adults, and commitment to continuing education. And they're pretty much evaluated on a scale for these competencies and areas that they feel they can improve. So now to my study. What I did was I conducted a qualitative phenomenological design. So I wanted to take a closer look at the lived experiences of geropsychologists and therefore gain a better understanding of their perceptions of aging. The participants I included were 10 licensed geropsychologists working with older adults at least once a week in long-term care within the last 5 years. So the procedure is that I received IRB approval. I used the Zoom platform in order to conduct my interviews, and they were semi-structured interviews. So I had a list of questions, and then I went off of that. So I asked follow-up questions and saw where the conversation went naturally. Data analysis, I audio recorded, transcribed, and coded for themes. And I also used bracketing in order to mitigate my potential bias, if any, and interrater reliability with the help of my chair. So the inclusion criteria, like I said, licensed clinical psychologists working in the field of geriatrics. Participants needed to be available for an interview lasting an hour, working at least 1 day per week in a long-term care setting for at least 6 months within the last 5 years, and comfortable discussing their experience of working with older adults in long-term care settings. So this was my, these are my participant demographics. I'll just leave that up for a second. So I made note of the gender, race and ethnicity, year they were licensed in psychology, in clinical psychology, number of years they specifically worked in geriatrics, and number of days a week working in a long-term care setting, and then additional populations they work with, if any. These are my interview questions. I won't go through each one, but it basically covered positive aspects, challenges, if any. They were all open-ended questions. What did you think it would be like to work with older adults? So initial perceptions. What aspects, if any, do you enjoy about the work? And where do you see yourself growing and further developing as a geropsychologist? Competency, things like that. So right here, you can see my thematic analysis. So I found themes and sub-themes in the participants' responses, and I'll go into greater detail in the next several slides. So the first theme that that evolved from the research would be that these psychologists felt being part of a system and using a team approach was incredibly important and beneficial. So actually, all of the participants discussed the importance of working within an interdisciplinary team. And in long-term care, older adults have a variety of medical needs, like I talked about earlier, and those all need to be addressed in treatment in order to have the best quality of care. Comprehensive care is crucial in these settings and with this population. So two of these quotes right here from two of the participants. When we're all on the same page, things seem to run more smoothly and effectively, and this ultimately helps the client. So this one really reflects that interdisciplinary approach and covering all of the bases, having a true knowledge of what's happening with the client, comorbid conditions, everything. Somebody who is a troublesome person for them, they feel like I've got their back and I can help ameliorate some of their problematic behaviors. Also, helping staff discover who this person was so there can be a greater understanding and support success. So this participant really highlighted that team approach and support. Another way that working in a system where people support each other, where they're willing to help each other, that it's really beneficial for helping each other and also their residents, their clients. Older adulthood is often perceived as gloomy and bleak. Participants acknowledge the importance of team support and communication and the ways that it can decrease burnout among staff and healthcare professionals in these settings. So by utilizing a teamwork approach with open communication and empathy, things can run more smoothly and effectively. So one participant noted, having dedicated people that work in these facilities helps you cope with the dual surroundings. Helps with burnout, look forward to going to work in a friendly environment. And another participant said, I feel like I'm not only helpful to my patients in most cases, but also to staff in terms of being supportive to them. I can't treat their mental health problems, but I can definitely listen and be open and be supportive of them. I get frustrated with administrative issues. Sometimes I feel like the administrative issues in a nursing home really get in the way of taking care of people. So this actually highlights what I was talking about in the beginning with the systemic issues, or the beliefs and values, thoughts and behaviors of the staff, and how that can greatly impact taking care of the residents and their needs. The next theme that I found in this study is the creative interventions and outlook on progress. So therapeutic progress can look different depending on the individual and the setting. Several participants noted that therapy takes some thinking outside of the box. So for example, helping a client feel comfortable, feeling like they're people, and like they still matter, that there's value in what they have to give and who they are. So one of the participants said, consider out of the box treatment instead of just upping medications, like phototherapy with a patient who has seasonal affective disorder. So thinking of a creative intervention in order to connect and build rapport with their client. Another gyropsychologist said, what can I give my client if this is our only encounter? Is it just human connection for some? So really taking the time and thinking about what would be really beneficial to my client. Is it going by a manualized treatment, or reading out of a book, or whatever it might be? Or can I be more creative in order to really build this connection and have them benefit, ultimately increasing their quality of life? And then another participant said, working with older adults really does bring home the existential questions of, what am I going to do with the rest of my life, in a very visceral way, and helps you with that Buddhist, just be in the moment, enjoy what you can in the moment, because fundamentally, that's all we really have. In addition, what other ways can psychologists treat their clients and increase quality of life? So as you can see, there is a degree, I think, of comfort and competency that needs to be met in order to utilize more creative interventions and thinking outside the box. And also that comfort and ability with sometimes talking about life's biggest questions, and so existential or fear of dying and things like that. So 2 more participants, I highlighted their quotes. I think a lot of people in our field are scared to talk about that: aging, death and dying, sex and body parts. It's uncomfortable. I think that might be why we don't always see this pull towards this population. Another participant said, staff was shocked when a patient wanted to masturbate. She's still a young woman. Why are we freaking out? Just because you're older doesn't mean that those desires or wants go out the door. So this really highlights the comfort a psychologist has with talking about taboo topics, increasing quality of care by letting the residents know, I'm okay to talk about this. I'm comfortable talking about this. And I know that you still think about these things, and it's normal and it's okay. And I'm not afraid to go there with you. And seeing how that really benefits the alliance and the care that the clients are receiving. So another theme, participants spoke about the misconceptions of aging that are tied to negative and depressing outlooks. Unfortunately, this bleak, overgeneralized outlook is easily adopted by society and further demonstrated in ways I'm sure we see every day, various contexts, such as in the media. And participants in this study identified the diversity within older adulthood, and specifically the heterogeneity. So, kind of going against what we are sometimes taught in the media and what society has really created in this sense of how we see older adults. One quote that I thought was pretty reflective of this: I guess that's the other thing, that there's so much variety from one person to the other in what they're dealing with. Like two 80-year-olds can be in totally different situations. It's also fun to see the people that age successfully. You see people that don't, and you see a lot of in between. But every now and then, you see people that really got it all right. They were fortunate. They had a good outlook, the personality traits. Sometimes it's really kind of neat to see that too. Another quote that I thought was pretty important, because it talked about aspects that are in control and aspects that are not that an individual might not be in control of in terms of healthy aging. Aging isn't a futile, depressing pathway. It's varied. Some of it is varied by genetics, our privilege, and our socioeconomic status and childhood adversity. A lot of it is also informed by choices, diet, exercise, managing chronic disease, mental illness, treating depression, and anxiety. It's important to also consider what's in your control and what's not. It's inevitable that the personal aspects of aging and the work will intertwine and sometimes impact each other. Another theme, misconceptions about aging as gloomy and depressing. So many of the participants discussed how our ability to talk about older adulthood may be culturally specific as well, and based on experiences growing up and what we've been taught. So one participant said, constantly reminding them to use their cane, grab your cane. Canes look like a disability status. It's a sign of, again, deterioration. Seniors used to be a part of the fabric of our lives, but not in America today. We don't want to think about getting older. We like to fight it. So if we think about all of the ways in which society teaches us that we have to fight aging by using different products, or just not living as if getting older is a normal part of life, and it's something that is a great, it's a good thing. It's a good thing that people are able to get older. Another participant stated, I grew up in Georgia, and in rural Georgia, there's a little bit more respect for elders than I saw when I moved out of the area. So I think I had kind of a little bit of built-in patience and willingness to listen. I've had good experiences with older people in my life. So this participant highlighted the impact of earlier experiences and having maybe older family members that really helped this participant develop her views of aging and perceptions. And the last thing that I found is understanding loss. So several participants discussed how they experience loss in a variety of ways, such as the loss of clients over time, their clients' loss of a younger sense of self, the role that older adults used to have in their families as a caretaker, loss of friends, family. So I have a couple quotes that highlight this. One participant said, because it is hard, there's a lot of grieving and there's a lot of loss of autonomy, loss of mobility, loss of even memories and cognition that can be hard for people. You know what I mean? Another participant said, there's a lot of grief and loss in this population, not just with the loss of loved ones, but the loss of their independence, the loss of their role as a caregiver to their kids, the loss of their job. They retired. They don't know what to do with themselves. They lost their identity. All kinds of loss, and usually that's a trigger. I use that. I always had a glass of wine or two with dinner for the last 30 years, but after I retired, my drinking really took off, something like that. So we have a lot of people who were either regular users that it's become more of a problem over time. So these two quotes really highlight the variety of experiences involving loss. So whether it's the loss of a role, loss of independence, loss of mobility, autonomy, all of those things. This quote's a little long, but bear with me because I think it really encapsulates what this theme describes. So one participant said, but you said something about change. And so one of the things that I didn't realize is in certain medical concerns or medical disorders, your esophagus starts to no longer work. And the psychology behind you can't eat anymore, whether you have a G tube in or you can't chew and you have to have pureed food. I never even thought of that until like within the last month and a half. And so now we're talking about the psychology of not being able to eat. Funny, you're eating, but you're not eating. I said they want to put a bed rail on your bed so you don't roll off and hurt yourself. She's like, I don't need that. And I was like, you rolled off the bed last night. We want to keep you safe. We got to do something. And she's like, I am not a baby. And I said, huh? And so they're also providing me this education of, again, that idea of thinking outside of the box. So my one client can't eat pizza anymore. And so now we're talking about what it was like to eat pizza and what she enjoyed about it versus now she has to have pureed pizza, which I didn't know was a thing. So this quote actually highlights not only loss of independence with eating, maybe even dignity, but also I think it really talks about more than that, thinking outside of the box, and the fact that this psychologist was able to take a step back and change her thinking in terms of treating this client and what would be helpful. And that might be just talking about what things used to be like, how is it now not being able to do the things you used to do, and not being afraid to talk about these things with their clients. So the clinical implications of my study, I found that unique and specific training for working clinically with older adults is beneficial. Specifically, training should emphasize flexibility in treatment, planning, and what you're working on with your client, your thought process, creativity, team approach, so support and communication within an interdisciplinary team in these long-term care settings, heterogeneity within the older adult population. So not all aging is the same. No one ages the same way. And there is healthy aging. There are factors that are in control, that you're in control of, factors that are out of your control. But it definitely varies, that it's a very unique and varied population. And willingness to explore grief and loss and other taboo topics. So things that might push people away from specializing in this population. It might be beneficial to actually dive into it and be willing to have those uncomfortable conversations, or think about, why am I not as comfortable talking to this person opposed to a teenager? Is it a fear of my own that I have about dying, or whatever it might be? So in conclusion, geropsychologists' responses were very consistent with the recent literature examining systemic and individual challenges in long-term care settings. And the responses were also consistent with the diverse aging process. So the fact that there's a lot of heterogeneity and different experiences of aging. It's impossible to generalize older adulthood, and many geropsychologists find this work to be rewarding and fulfilling based on the relationships they create, the stories they encounter, and the creative ways they are able to connect with their clients. And I was very happy to learn about this and see that that was one of the big results that I found. Some limitations in this study are that the sample was limited in terms of race. So I think you saw in the beginning that there was one Asian American participant and the rest were Caucasian. So there might be more cultural implications that can be associated with competency or comfort working with this population based on their personal experiences and things that they learn. All participants have worked in some capacity of geriatrics within the last 5 years. So it could be potentially interesting to see psychologists who didn't meet that criteria, because there were a couple that I couldn't include in the study because of some of the numbers. Discussion and future research. So it's known that nursing homes and other long-term care settings are the perfect storm during a pandemic. And we really saw that with the impact of COVID-19. This means that most residents are ill and immunocompromised. They're living in close quarters with roommates and other residents. They're cared for by staff living in the community, so going back and forth from work to their own families and their home lives. And also some aren't required to be vaccinated, so that's another concern. The COVID-19 pandemic has affected the mental health of long-term care residents through infection, but also through social isolation and psychological stressors. So a lot of residents they had to make this adjustment with feeling like they're losing their independence, their dignity, in many ways, mobility and things like that. And now with COVID-19, it really compounded that. They had to deal with further isolation and more adjustment to a routine that maybe they just became familiar with. This definitely has impacted memory care units and residents who suffer from dementia. So the impact of stress and adjustment with their routine. And also telehealth. So many older adults might not be, older adults in long-term care might not be comfortable or familiar with technology. So having to make this shift of not being able to see their family and friends in-person visits, but then they're having to learn how to use a laptop or on a phone, and the staff are navigating this, and it can be a huge adjustment. Also, training programs in graduate school. I think that was another important factor for future research. So greater emphasis on late adulthood and lifespan education. So like that Pikes Peak model and different factors that can improve competency and comfort with this population, a willingness to learn, flexibility, creativity, and students also learning from geropsychologists and mentors themselves. So learning from the people who are actually in these experiences and can share what they're learning and what they're actually doing. So I just want to take the time to really thank my chair, Dr. Sachs, and also my committee members, Dr. Methacolum and Dr. Rothery. I really appreciate the time and the effort, the support. This took a little longer than I wanted it to, and I just really appreciate the patience and the support that was given to me, specifically from my chair, Dr. Sachs, and her knowledge on this population as well, and the work of geropsychologists. And I also want to thank everyone who attended. I'm opening up the screen. Stop share. Okay. Oh, Dr. Sachs, you're on mute.
Somehow I still do that all the time. Congratulations, Hannah. That was a wonderful presentation. I just want to open this up for comments and questions from all the wonderful people that are here.
Can you hear me?
Yes.
Okay, I apologize if I break up. I'm having Zoom issues. So I have a couple of questions, one of which may have been answered by the picture at the end, Hannah, and I agree with Dr. Sachs. Beautiful, beautiful job. Very, very, very important topic. I was curious about your interest in this topic, in this population.
Yeah, I describe it as I've always had this interest in working with older adults, and I still do. And I find it to be so important, the growing need. So there's a greater demand than I think the supply of geropsychologists who feel, or psychologists who feel confident and like they really want to be doing this work. And it's also, I mean, it's sad how society really perceives older adulthood. And I think specifically in the United States, um, I would have to read more about in other countries, but in places. However, that's what I was learning from my participants, that it is seen very differently. And there's a lot more work that we can do to take care of that population. And so I think that's what really drew me in.
Okay, good, good. So, yeah, and I remember Dr. Sachs actually did another study with another student. I don't think it was a dissertation, maybe a master's project, to see whether exposure to like doing a practicum placement with the population, taking courses and things of that nature, unfortunately did not seem to increase interest. I think the thing that did increase interest was having positive experiences with older populations growing up. And so it's almost like it's something you can't teach. It's something you have to come with, a value you have to come with from your own experiences.
Yeah.
That said, yeah, that said, can you tell us a little bit more about the cultures that do revere senior populations? Like we know, I think the culture that is most often acknowledged is various Asian cultures in terms of respect and viewing aging with wisdom. Are there other cultures that you in your research learned about that also revered growing older and wiser?
So definitely Asian cultures. And also one of my participants, she works on a reservation, and she found that a lot of the so with Native Americans, the not only the residents but also specifically the staff and the professional health, the care that they were receiving, there was more of a family based unit or way of working with the residents and a willingness to want to come into work and really increase that quality of care. So that family-based,
Mhm,
I guess, desire. Um,
mhm.
yeah.
Okay. And I guess my final point is when I think about the African American population, um, there is a healthy cultural mistrust of um, for lack of a better word, institutionalization
Mhm.
of family members. And so I'm thinking that one reason why, for example, African American psychologists might not be interested in working in such settings is because culturally um, they would prefer to, you know, African American folks would prefer to keep their loved ones at home
Mhm.
and take care of them at home because of the healthy mistrust of the system. And that's not the case for everyone, but I think that's the case for many. So I say that in response to your comment that perhaps there's not more diversity in the pool of psychologists working with these populations because of lack of comfort or lack of competence.
Mhm.
Um, and so I think that might be another reason, at least for some populations, that those aren't places that they want to see their loved ones, and so they don't think about those populations as a focus, at least not in that setting, an inpatient setting or residential setting.
Yeah, absolutely. I think that is another area that would be important to look at specifically. The study didn't look at that as much, and I think that would be helpful. One of the participants I had actually pointed out the use of the term institutionalization,
Mhm.
and she addressed the negative
Yeah.
connotation or the negative perception of using that word. And
Hmm.
that's why I tried to use the term long term care settings. And it really made me think how just even that word over time and the
Hmm.
negative attachment or stigma to using that terminology, and what is that saying about the people we're caring for and the setting that we're caring
Hmm.
for them in.
Absolutely, absolutely, very important point. Thank you. Yeah. Okay. Nice job. I'm done.
Dr. Rothery, I just have a follow-up comment. Having been someone that works in these settings, is one thing that I've noticed as a white clinician is that I see a lot more family involvement with African American clients than I do with my white clients, who often feel really isolated in these systems. And I've had
Mm-hmm.
more success working with families, in the room together
Mm-hmm.
with those clients. And I think that they tend to have a better go of it in terms of interacting with staff around that than when it's just done
Mm-hmm.
in an individual way. And so I think that kind of speaks to the flexibility that Hannah's talking
Hmm.
about, although that didn't come up in the study. I think that's
Yeah,
another important skill,
Right.
kind of working with the system, with them.
Yes.
that's interesting.
Right. So if they're going to be here, we're going to be actively involved. That's good to know. Yeah.
Yeah, that's really interesting. Thank you.
Mhm.
And great job. Congratulations on a wonderful presentation. Just had a question about I know you had asked specifically about the type of training that the
Mhm.
participants received. However, I don't know if you included that in your presentation. Did any of the psychologists talk about that, the specific training that they received?
Yeah, so actually, a lot of the participants didn't receive training in graduate school or in their doctorate level programs. They had to seek training beyond that. So finding workshops or speaking to mentors, a lot of them fell into this work through talking to a mentor in a graduate program or at a clinical site. And in that way, they have built their training and sought opportunities beyond their graduate education.
Mhm. And then, and what did they feel like? I know one of the other questions that you had for your interview was their further development and where they see kind of their career taking them in terms of being a general psychologist. what did, what did they say? What did you find about that?
Yeah, so actually one of the participants, I loved hearing what she had to say because it was very positive, but also very real. She wanted to, um, this was actually the one that talked about using a cane and reminding someone to take your cane, use your cane, and how dull and bleak that can sound because a cane, the perception is that it's deterioration, that it's not exciting, it's not something that an older adult might want. So really being creative with that and making something fun of it. So making more appealing canes or drawing attention in with specific interests in order to make it more exciting and more personalized. So it's not so generic and gloomy and just a representation of deteriorating, which is also wrong in many ways too. And she also talked about creating a podcast about talking about misperceptions of aging and specifically highlighting healthy aging.
Mhm. And that might be even something for you to include, like, in like just training implications. I know you had a piece on graduate training programs, but what else could be included to reduce the misconceptions?
Yeah, absolutely. Thank you.
Or have.
So Hannah, congratulations. This was a wonderful presentation, and it was so interesting actually for me to read the responses and to sort of see how they fell in line with my own experience in geropsychology, and it was very consistent. Um, One of the things that we talked about toward the end of the study that really to me feels like an important area for future research, and that you did mention, was the impact of COVID. I actually, after we finish today, I'm going to be doing some telehealth in a nursing facility. And it's been interesting. I think in terms of working with the system, that's been an interesting process because you have to literally have somebody to bring the iPad and set it up in front of the person and kind of let them, you have another person in the room in some sense, in some ways. But I think that in terms of the experience of the clinician, one challenge we have is sort of supporting our clinicians, because I know among my peers and in my own experience, there's been a sense of hopelessness when you're working with somebody who hasn't been able to leave their room in a year. And the sense of how do you counsel somebody under such difficult circumstances, and what tools do you have when there are those limitations beyond that really humanistic, interpersonal moment of connection. And so I think that that's been difficult for both, for everybody working in the field of geriatrics. And there's a lot of trauma among the staff as well in the COVID era. So I'm curious to see what the long-term impacts of that are for us culturally.
Yes, Dr. Sachs, I'm glad you brought that up because I had it in my notes to address that point, and then I guess I was just too nervous and I skipped over it. But the impact on geropsychologists during this pandemic, and also having to, in some ways, compartmentalize their personal psychological stressors, losses they are having, and health issues, their feelings about the pandemic, and being able to really figure out how to navigate that while they're working with clients and their losses at the same time. Yeah, so thank you.
I guess the other thing that I wanted to bring up is the idea of the mentorship, because I do think that's so important. I think that sort of as you describe it in the study and in my own experience, there's sort of a journey of working within these institutions or working within these long-term care settings where initially it can be very overwhelming from an existential perspective, but that over the time, like you said, it's kind of that exposure to your own existential fears and thoughts about death and, the length of life and about inevitable losses. I think that part of that journey for the geropsychologist is to kind of become more at peace with that and to feel more comfortable with those issues over time. And that's part of the positive experience. that's kind of difficult to articulate, but I think kind of came through in some of those responses.
Yeah, absolutely. Yeah, that's a really good point. Thank you.
Any other questions or comments from our guests today?
Did a great job. That's all I want to say.
Thank you, Whitney. Thank you, Larry.
What I'm going to do now is create a breakout room for the committee so we can discuss. So Hannah, if you can stick around, we'll come back in a little bit. Okay?
Thank you.
Hold on a second.
Thank you.
I watched the whole presentation.
Thank you so much.
I just don't know what to say. I just cried.
Oh,
I'm so happy. So
thank
happy.
you.
You did talk about the seniors, so you got one right here. He's grandpa. So that's it.
Oh.
You got your seniors, that's for sure. You can study on us. Funny how much we love you, how much we're proud of you, and oh my God, and all the support that my grandson gave you all through this time.
He did.
And of course, our little princess Emma.
Thank
So
you.
mommy's a doctor now. So now we got to teach her to say doctor. Mommy, doctor. Okay, man, I'll talk to you later, baby.
Okay, thank you so much. Love you.
Love you. Love you a whole bunch. Okay?
Thank you.
Great job, Hannah.
Thank you.
All right, guys. So what we're going to do now is we're going to close everything out. I believe this is going to be the finalization of everything. And here we go. Thanks again for everybody who participated.
All right. Greetings again, everybody. We just wanted to come back and congratulate Dr. Rawle on her accomplishments. We were really pleased with this dissertation and so interested. So yes, a round of applause. It's been a wonderful thing. So please call her doctor now as much as possible until she can get used to it. It's been a long journey, but a good one.
Will do. Great job, Hannah. Congrats.
Excellent. Congratulations.
Thank you.
Love
Congratulations, Hannah. Love you.
Thank you. Love you too.
you. So proud of you.
You know, virtual brunch out on a table somewhere.
Yeah,
Dr. Rawle. Sounds great.
Go ahead, Grim.
Dr. Rawle.
Dr. Rawle.
Dr. Rawle, Dr. Hannah, hey.
We all gotta call you doctor. We gotta get Emma to say Dr. Mommy. Dr. Mommy. Hello, everybody out there.
Hello.
Hi, Marianne.
Hello, Sandy. Hello, everybody out there.
Hi.
Family. It's one proud day for all of us. One proud
Absolutely.
day.
Good reason.
All
to
right,
do that.
Dr. Rawle. We
So
love you.
I have to go, but I will leave the screen up for you all to visit and chat as long as you would like.
No, we can close it. It's okay.
Very good. Well, congratulations, Hannah. Have a restful rest of
Congrats.
the day. And
Thank you so much.
nice to see all of you.
Congratulations. Yay.
Thank you. Thank you for coming, everyone. Take care.
Bye.
Bye.